Hi, this is Dr. John Mahoney with another segment pertaining to the health and wellness here at the IBEW. This afternoon I'm with my colleague, Dr. Kenneth Rice, and I welcome you, Ken. Thank you for coming.
Well, thank you so much, John. I'm excited to be here and to help out with this very important policy of prevention and staying ahead of the game.
I have learned so much from you in regard to echocardiography and carotid ultrasound. I'd like to ask you to speak a bit on certain symptoms a patient may present with that would trigger your decision to do that kind of testing.
Yeah, ultrasound or echocardiography is one tool that we use to look at the heart by imaging with ultrasound, and it shows that you can see the entire heart structure and the covering of the heart. Some young people come in with chest pain that you might think is heart-related insofar as coronary disease, but oftentimes they have echocardiography will show that they have inflammation of the covering of the heart, the pericardium, with fluid that develops beneath that covering, and it's called acute pericarditis, causes chest pain that can mimic heart attacks and be very severe in some patients. But you can make the diagnosis of that very, very quickly if you suspect that, especially if they've had a viral syndrome within the past few months. That can predispose them to acute pericarditis at any age, 20-year-olds. I've seen a lot of students in dorms passing around viral syndromes, and many of them present with acute pericarditis. We probably see a small proportion of those in the office.
So it's wonderful to do these tests, but you still have to be the doctor, the detective. Know what setting the patient presents to you with. A student in with a recent viral syndrome and that type of pain. It's something that you don't necessarily pass off, and the test can be critical, to give you the information. Can I ask you also, sure. Women might present differently in terms of coronary artery disease. What do you listen for?
In the past, years gone by, when women presented with funny type of symptoms, either fatigue, which was new, unusual shortness of breath, very vague chest discomforts, which can be any discomfort above the waist, theoretically. Angina could be any discomfort above the waist all the way to the top of the head, which is rare, but I've seen cases like that, and they've been reported. But women will present more atypically than we guys, where we have more typical acute onset of chest pain, radiating down the arms and with associated nausea and excessive sweating or diaphoresis. So women will present with oftentimes with fatigue and a very nondescript pattern of chest discomfort.
Sometimes in the practice of medicine now, I think a lot of physicians feel like we'll do an echocardiogram or we'll do a carotid ultrasound if things really get worse. What you're really teaching me is that if you have a risk factor, suspicion, and concern, you do those tests early on, and they can give you so much information to help prevent bad things down the road.
We can be fooled. I've seen a 29-year-old gentleman present at a major hospital and sent home with just atypical chest pain, it was called, and because he was 29. I met him later, and the following day he had a major heart attack, and that's not to impugn any hospital, but to say that we have to be, as cardiologists and as physicians, we have to be aware of these patients who present typically, or women who present more atypically, of their risk factors and their what we call Bayes' theorem, their pre-test risk for having coronary disease, just by talking to them.
That's true. In closing, I'd say that in spite of all that we feel we understand, we listen to, work day by day and do these tests, medicine always come back and humble us.
It is humbling. It's an exciting field where we've made great strides over the past 30 years, far greater than we had in the past, and we can not only, we have the tools to do more detective work when we have suspicions, but we also have the instrumentation now and the procedures to help not cure most patients, but to treat them definitively, especially in coronary disease. We can stent coronaries that are blocked. even carotid artery disease. If they have severe carotid stenosis or blockage, we can, the classic technique is to open the artery and take out the plaque by a surgeon, but we also can stent them now, analogous to coronary stenting, put a metal scaffold into the carotid and open it up in that fashion. So things are progressing very rapidly and for the patient's benefit.
I want to thank you so much for coming, and it's very helpful to the members of the IBEW and the families to get involved with this kind of information and this discussion as medicine is evolving so rapidly. And
well, thank you so much for having me, John. This was a very fascinating discussion for me, and I hope to be able to do this again in the future for you guys.
I learn so much every time I talk to you.
Thank you.
I want to thank everyone for listening today, and I'll see you next time around.